Hello everyone, a very warm welcome. I am Dr. Masood Khan. Today we'll take history for a long case. A 28-year male Muslim, Mr. Zahir Ahmed, son of Mola Bakhsh, unmarried, teacher by profession, resident of Karachi, admitted in JPMC through OPD on 14th of July 2024 with presenting complaint of loose stools for 6 months. According to the patient, he was all right 8 months back. He is non-smoker, non-alcoholic, non-diabetic, non-hypertensive, as presented with loose stools. Loose motions were insidious in onset, non-formed stools, brown in color, large in quantity with mucus and blood, not foul smelling, can easily be flushed 4 to 5 times a day for 5 to 7 days at a time, remains well between episodes. He has several episodes of diarrhea during last 6 months. There is no aggravating factor or association with gluten-free diet, milk intake, artificial sweeteners use. The loose stools did not relieved by any specific factor, did not relieved by specific position or fasting or defecation or any anti-diarrheal drugs prescribed by his local doctor during last 6 months. While in each episode of diarrhea, patient develops fever, malaise, painful oral ulcers, skin rash, painful eyes. Patient denied any racing of heart, lumps and bumps in the body, excessive sweating in night, swelling in the limbs, yellow discoloration of eyes, pale stool, bleeding from any side, bone pain, muscle ache, night blindness, any TB contact, unboiled milk intake, any darkening of the skin color, and any darkening of the face. There is no history of whistling sounds in the chest, abdominal pain and distension. No history of antibiotics, PPI, SSRI, anti-constipated drugs like lactulose, any magnesium containing supplements. No history of joint pain medication use or previous immunotherapy, chemotherapy, intestinal surgery, and travel to northern areas. There is no history of drug abuse. While in ward, patient was given IV antibiotics, IV steroids, IV fluids. He is being investigated for blood tests, CBC, ESR, C-reactive protein, serum electrolytes, LFTs, colonoscopy, and endoscopy. The reports are awaited. TSH, IgA level and IgG levels are also sent. Anti-endomysial antibodies, stool DR, FOB, fecal occult blood, barium enema study is also done. Colonoscopy with biopsy, report awaited. Patient has no blood transfusion history in the past. There is no history of inflammatory bowel disease or CA colon in the family. No history of extramarital affairs and exposure. Patient is not allergic to any medication. He is not using any medication at home before this complaint of loose stools. No history of previous hospitalization. Vaccination for PPI and COVID-19 vaccination taken. Patient is physically well built and mentally sound. He lives in a Pakka house. Source of income is 70,000 salary per month from teaching profession. Drinking water is from water pump. There is no history of pets at home. Sanitation is good. So this is the history of a patient who comes with diarrhea for last 6 months. All his investigations are done and they are awaited. Now, on history basis, what is uh, the, the cause of this diarrhea for last 6 months? So the first is to differentiate large bowel from small bowel. In this case, we have differentials like inflammatory bowel disease on the top, intestinal tuberculosis, and CA colon. Now, why inflammatory bowel disease? In history, the patient told us that in each episodes of diarrhea, there is fever associated with malaise and oral ulcers. So this points to inflammatory bowel disease. Number 2 differential is intestinal tuberculosis, very common in our part of the world. And number 3 is CA colon. So this is the differentials. And now on history base, what questions we should ask this patient further to evaluate? That is nocturnal diarrhea. Is there any loose stools at night? Nocturnal diarrhea always points to organic disease. Number 2 question, does the diarrhea relieved with fasting? Any diarrhea which is relieved with fasting, it shows secretory diarrhea, that is non-inflammatory diarrhea. So these are the first two questions. And now the examiner may ask that whether it is large bowel diarrhea or small bowel diarrhea. So small bowel diarrhea has large quantity of loose stools, while large bowel diarrhea has small quantity of stools. So mucus is present in large bowel diarrhea. And is there any association with tenesmus, that is incomplete evacuation? It is associated with large bowel diarrhea. So these are few questions in history taking. Now malabsorption needs to be ruled out. Malabsorption like lactose intolerance, the patient diarrhea is aggravated with milk. In celiac disease, the wheat or gluten containing diet worsens the diarrhea. There is growth retardation in celiac disease. And past history of celiac disease, pruritic rash is very common in celiac disease, that is dermatitis herpetiformis. While Whipple's disease needs to be investigated, that is heart problem, dementia, and arthralgias in large joint. Tuberculosis, intestinal tuberculosis, they may present with TB contacts, positive TB contacts, and unpasteurized milk intake. They are associated with tuberculosis. While Crohn's disease, the entity of inflammatory bowel disease, Crohn's disease needs to be investigated. There is swelling in the right iliac fossa or right sided of lower body, abdominal pain, bloating association, mucus formation, and family history of intestinal disease. The further workup or interrogation includes endocrine history, diabetes mellitus, hyperthyroidism. Carcinoid can present as diarrhea, the ZE syndrome, Zollinger-Ellison syndrome. It can present as diarrhea and Addison's disease. For Addison's disease, we need to ask about the darkening of complexion and dizziness on standing. The pheochromocytoma, it can present as uncontrolled hypertension, sweating, headache, palpitation. Chronic giardiasis present if there is travel history, uh, positive giardiasis can be suspected. Chronic pancreatitis leading presenting as chronic epigastric pain radiating to back, and there is history of greasy stools and foul smelling. They are associated with chronic diarrhea. Autoimmune disease like scleroderma is associated with tightening of skin, difficulty in swallowing, shortness of breath, difficulty in opening of mouth, so they can present as diarrhea. Now, large bowel ulcerative colitis, does the diarrhea is associated with blood in it or polyarthralgias, abdominal pain, and any family history of intestinal disease. So, ulcerative colitis and Crohn's disease questionnaire should be asked from any patient who has history of chronic diarrhea. HIV status and rectal carcinoma is another cause of diarrhea, and antibiotic associated colitis is also one of the important cause of diarrhea. Laxative abuse, ischemic colitis, they can present as chronic diarrhea. Now, mix small bowel and large bowel diarrhea symptoms, like in our patient, there may be tuberculosis, HIV, and inflammatory bowel disease. Now, the history should be regarding these questions and these causes. Any history of gallstones and chronic epigastric pain, that should be investigated, and oral ulcers in case of IBD, it's very common, and history of chemotherapy, immunotherapy previous, that should be investigated, that should be asked. Now, radiation associated diarrhea, that usually involves the large bowel, while chemo induced diarrhea, or they can involve small bowel. The bacterial overgrowth, it leads to, it is because of the small bowel diarrhea. Now, chronic diarrhea, weight loss question should be asked. Night blindness, it should be asked. In case of deficiency of fat soluble vitamins, the vitamin A deficiency, it can present as night blindness. And oral lesions, perioral lesions, air loss, that is common with vitamin B complex deficiency. Swollen gums and skin changes, they are due to vitamin C deficiency. It can present as chronic diarrhea. Vitamin D deficiency ultimately leads to bone pain and difficulty in raising from sitting position. Any bruises over the skin, over the body, it shows the vitamin K deficiency. And vitamin E deficiency leads to skin and air changes. Protein losing enteropathy can present as diarrhea, in which there is generalized body swelling, anasarca. Small bowel diarrhea can also occur with small bowel lymphoma. Addison's disease, bilateral flank pain, it can present as diarrhea. While inflammatory bowel disease, there is yellowish sclera, primary sclerosing cholangitis is very common with ulcerative colitis and CA colon, especially the pancolitis involvement leads to CA colon. While the IBD is also associated with hair loss, redness of eye, oral ulceration, neck swelling, thyroid associated with other autoimmune disease, very common IBD with thyroid, hypothyroid, hyperthyroid. So these questions needs to be asked, like skin rash, any associated fistulas, and further investigation include psoriasis needs to be questioned, and ankylosing spondylitis, inflammatory bowel disease, Reiter's disease, and seronegative spondyloarthropathies needs to be questioned. Any history of silvery scale skin rash, that is psoriasis. Back pain with stiffness is common with ankylosing spondylitis. Burning micturition with genital rash, Reiter's syndrome. So, tuberculosis, intestinal tuberculosis associated with night sweats, lumps and bumps in the body, history of productive sputum, any history of abdominal pain, abdominal distension, history of yellowish discoloration of the sclera, bilateral lower limb weakness, back pain, numbness of hand and feet, and history of darkening of skin complexion and dizziness on standing. So these are the questions and causes of chronic diarrhea in any patient. So osmotic diarrhea, IBD, seronegative arthropathies, autoimmune diseases like Addison's disease, diabetes mellitus, hyperthyroidism, they are all associated